Thank you, Dr. Mighty, for your excellent presentation. I welcome back Dr. Shivam Mittal.
Yes, it was a very interesting talk by Dr. Tanmoy and Dr. Fasano, and I will, yes, finally. So I'm excited to have my slide on the presentation podium here. And as we discussed today, I'll be talking on botulinum toxin in movement disorders beyond the obvious. Very briefly, botulinum toxin was this mask? Clicker, okay. Oh. So botulinum toxin was initially discovered when there was sausage poisoning in Germany, and that time we discovered this is a toxin which is released by Clostridium bacteria, and this is a very, very toxic material and very lethal dose. Its lethal dose is 1 nanogram per kilogram. Is the most poisonous substance known to mankind, and somehow we were. So we know that we have been able to take out the good part of the botulinum toxin and use it in clinical practice. The way it works, probably everybody is aware that it disrupts the release of neurotransmitter acetylcholine into the postsynaptic membrane. As a result, there is a neuromuscular junction blockage. As a result, what happens after injection, there is no neurotransmission, and as a result, the muscle becomes paralyzed and becomes weak transiently. Now, there are 7 serotypes of botulinum toxin available. The one that we use clinically are type A and type B. In UAE, we don't have type B available, but we have type A. There are 3 clinical botulinum toxin available. One is called botox, which is the ONA botulinum toxin. There is I make it short, ONA, INCO, EBO. EBO is Dysport, and INCO is Xeomin. All 3 are type A botulinum toxin. Type B is myoblock, which we use more sialorrhea, mostly in US, not available in UAE. Now, on the left-hand side, you can see the green color. This is the obvious conditions that we have been using botulinum toxin for. All these conditions: cervical dystonia, blepharospasm, limb dystonia, hemifacial spasm, oromandibular dystonia, bruxism, spasticity, sialorrhea, which is drooling of saliva, neurogenic bladder, and I wrote it twice. Now, on the right side is not the obvious. And this is, I will be touching on all these topics very briefly because we have limited time, but mostly on the tremor conditions, which is my area of interest, pain conditions, truncal dystonia, restless leg syndrome, tics, and freezing of gait, possibly. So hemifacial spasm is the most common condition that I see in my movement disorders clinic. In my movement disorders clinic, in botulinum toxin focused clinic, I do not do spasticity or migraine. It's all movement disorders. In that, hemifacial spasm forms a majority of patients, and we know there is a nerve that is getting pushed by the 7th nerve. There's a compression on it. The most commonly involved nerve artery is a pica, which pushes on that. As a result, you have these spasms. Other reasons to look at is post-Bell's palsy, facial nerve injury, and things like that. I'll come to the video. So we can see this patient has a left hemifacial spasm. And the first step is to recognize these involuntary, irregular, clonic, or tonic movements. They can be very fine or they can be very clonic. Second thing is to identify other Babinski sign. So what is other Babinski sign? The picture on the below, where you see that patient is trying to raise the eyebrow up. That is called the other Babinski sign. That is telling me that patient is trying to open her eyes and it's not psychological. These are some muscles that we inject. I'm not going to go into the details. Blepharospasm, now that's a dystonia condition. Hemifacial spasm is just a peripheral myoclonus. This one is a dystonia condition where you have frequent blinking of the eyes. It can be a part of just an idiopathic isolated dystonia, focal dystonia, as Dr. Fasano mentioned in his talk, that we have to classify as isolated dystonia, is it combined dystonia? So it is an isolated dystonia, focal dystonia involving the eyelids. Very common symptom initially is just the frequent blinking of the eyes when you go to the bright sunlight. Patients, when they're driving, they feel that they cannot keep their eyes open. And you can intervene by botulinum toxin injections. I have had few patients who were tried on tetrabenazine and trihexyphenidyl and other medications instead of botulinum toxin. And unfortunately, I do not see good results in the long term. These patients develop secondary Parkinsonism, they develop psychiatric symptoms. I would strongly recommend only think about botulinum toxin injection when you see a patient of blepharospasm. Now, this is cervical dystonia. This is a very common condition. This is, I would say, the second most common condition that I would see in my Botox clinic after hemifacial spasm. This is the symptom of, again, a focal dystonia where we can see there's a twisting and turning of the neck towards one direction. This is a nice review article that we wrote with Dr. Jankovic, which going through all the treatment options available. As we know, the first line is still botulinum toxin injection. This is a patient who has, you can see at rest, the head is tilted towards the right, and there is definite overactivation of the right shoulder muscles. You can see the right shoulder is elevated compared to the left side. There is right trapezius activation, and there's a tilt as well. So patient had these symptoms, had botulinum toxin injection, and you can see there was a drastic improvement. Now the other patient, so this is the patient who has more of torticollis, where you see patient is moving the head to the right and it's going backwards. So we know the left sternocleidomastoid is pushing the head towards the right splenius capitis is pulling it backward. So these are the two major players in this patient. Had the first injection, and you can see the torticollis has improved, but the tilt is still there. So we know that we have targeted some muscles, but some muscles are still remaining. So we go for the second injection, and you see he says in the video, I feel 95%, 99% better. I can move my head in any direction. So identifying the muscles involved, giving the right dose, going a systematic approach is the key for cervical dystonia patients. We have to be very careful because when you inject too much in the anterior neck muscles, it can cause disabling symptoms of dysphagia, voice changes, which becomes a problem because they would never go for Botox again. They'll say, you will counsel them, you will do great after 2 or 3 visits, but then they will say, no, I had a bad experience, I will never go for injections, and they'll be going around with acupuncture, with therapists, and everybody. So very important to get the injections correct the right first time. Now coming to other common condition is focal hand dystonia. As Dr. Fasano mentioned that we have these conditions where we have isolated dystonia or combined dystonia. When we have a brain eye, so what do we see on the MRI brain? Do we see eye of the tiger sign? Yes. So this is a NBIA where there's an iron accumulation, there's a hyperintensity in the globus pallidus bilaterally. This patient is a young lady who presented with left upper limb dystonia. Dr. Anna might be knowing this patient as well. We share this patient together. And this patient came to me with prominent focal dystonia in the left hand. This was disabling. Now, we diagnosed her that this is an etiology, and how do we treat? We treat with botulinum toxin injection. So she had focused injections using EMG guidance. So when the muscles are in the forearm, in the hand muscles, I strongly recommend to do EMG guided injections. In that case, we are very sure about the muscles that you're selecting. And usually with a small dose, as you can see, the doses of the muscles that I mentioned here. And patient had a very drastic improvement after the injection, and she was extremely happy. So now coming to more unusual or not so obvious is tremor conditions, which is the topic of my keen research interest. This is the first randomized control study that we performed and published in 2017 in Parkinson's disease patients who have refractory rest tremor, where DBS was not an option, or the patients do not want to get DBS, and medications was not working. In these patients, we did injections, and it was a botulinum toxin placebo-controlled as well, and there were significant results. So this is a patient who you can see that has a prominent right hand pill rolling rest tremor, and patient had botulinum toxin injection. The video is playing. Patient has very mild tremor. Tremor got much better, and after three months, as the effect wears off, the tremor is back, but it is still slightly better. This is another patient. You can see he has, so the tremor increases when the patient is counting backward. So now patient is counting, and you can see the tremor amplitude increases. So always important to check for the tremor when the patient is distracted. He's counting backwards. And this is a post-injection video. So you can see the tremor is still there, but the amplitude is much better. I always ask my patients, is the tremor bothering them? If they say yes, it is socially embarrassing, because when they move the hand, the tremor goes away. So it is not affecting the daily activities. But if it's affecting when they're praying, or they're meeting in a majlis, or they're talking to people or family, that's disturbing because they all focus at the tremor. Then in that situation, I offer them the injections. Now this is a timeline, this is a review article we published. There are only one randomized study published for Parkinson's tremor, but for essential tremor, which is the second topic, there are there are now three randomized studies published, and there's a phase 2 which is currently going on as well in US. And we did a randomized study in essential tremor as well, published in 2018. So there were three studies now. Jankovic published long ago, 96, Dr. Brin, and our study in 2018. And what we used was a novel technique of injection, which is more customized injection approach. In the previous studies, they were injecting 4 muscles, the flexor carpi radialis, flexor carpi ulnaris, extensor carpi radialis, and extensor carpi ulnaris, which caused some weakness in the hand muscles and was not used practically in the clinic. In our study, we use this customized injection approach where you give around 8 to 10 muscles with a lower dose based on the EMG activity, on the tremor activity, and that's a phase 2 study which is going on, following the same technique. And we call that as a Yale technique. I was a research fellow at Yale that time. So these are some result studies. You can see the Archimedes spiral, the tremor getting better. This is another tremor called primary writing tremor. Not very common. This is mostly seen in people who write a lot, mostly with writer's cramp as well. This patient, when he is writing, he has a prominent tremor. So he had injection of botulinum toxin, and the writing got much better. This is very, very tricky. Even a slightly more dose can cause significant weakness in holding the pen. So you have to go very, very general, very low dose to begin with. Writer's cramp as well. We all are aware of writer's cramp. Not very common in UAE, not common in US as well. In India, it's extremely common. In my hospital, when I was working in India for 2 years' time, 6 doctors had writer's cramp. So it is very common for mostly doctors and lawyers and IAS officers who write a lot. So this is how we do writer's cramp evaluation. So this is again an Indian patient that I saw. And you can see when he's writing, he has cramping. You look for mirror dystonia. You write from the other hand, and you look for the mirror dystonia or excessive movement, and you do neurophysiology. You put the needle in the muscle, and you ask the patient to write with the left hand, and you can activate, and you can actually see the muscle showing up on the EMG. I don't have a good sound, otherwise you can see the EMG images there. So, and then you know exactly which muscle is causing the writer's cramp. Now this patient has dystonic head tremor, mostly head tremor, which is a no head tremor, and had injection and had a good result. Now cerebellar tremor, that is also a very unusual condition. This patient had a very rare genetic syndrome, and that was cerebral ataxia causing head tremor. Ataxia of his body is not really bothering him. He is on wheelchair for many years, but head tremor was socially embarrassing. In this situation, I did botox injections in his splenius capitis in a small dose because it's very mild tremor. I'll show the video. And he's getting the injections every 3 months. It's been now almost 2 years, and very good results. At least it's helping him with the social embarrassment. I cannot do much for his ataxia, but for the head tremor, the injections helped. Now this is just published a week ago, actually 3 days ago. This is a review article with Dr. Pandey from India, botulinum toxin for the treatment of tremor. This summarizes all the tremor conditions, including MS tremor. So I have 4 or 5 MS patients who have a tremor, which is very different. It is not classifiable as rest, postural, but it is very different based on the lesion. And you can inject botulinum toxin in the right dose, and that really helps the tremor as well. Moving forward, axial dystonia, not very obvious condition. Patients can have bending forward like camptocormia or pisa syndrome, and this can be seen in Parkinson's and atypical Parkinson's condition. This is what typical of camptocormia. In these patients, the rectus abdominis muscle can be hyperactive, and that's why some studies have shown when you do injections into these rectus abdominis muscle, it can help. The use is controversial. We don't know really if that can be helpful or not. We don't have big studies. So it is a very highly desperate patient who wants to try anything. We can give a try. But again, this is rectus abdominis muscle. So it is very close to the peritoneum and everything. So it is high risk procedure. So I would not be jumping on this patient to do the injections. Pisa syndrome, yes, I have many patients with Pisa syndrome and very good results. So this is a reversible lateral bending of the trunk. Mostly it is seen in MSA patients, multiple system atrophy, but can be seen in Parkinson's disease patients as well. Can be an off-state phenomena which gets better with levodopa. If it's refractory to levodopa, we can offer botulinum toxin injections. This is a patient. You can see he has a very prominent laterocollis, Pisa syndrome, and that got better after the injections into the thoracic and lumbar paraspinal muscles. They usually need a higher dose, about 200 units of ONA, botulinum toxin A or botox. Another less obvious condition is oromandibular dystonia. Jaw closing dystonia is very common. We all know how to inject masseter muscles. Jaw opening dystonia becomes very challenging because you have to target the lateral pterygoid muscle and it has to be EMG guided. The results are again 40%, 50% improvement. It's not like 90% improvement what we see in jaw closing dystonia. So again, it has to be a discussion with the patient. So jaw closing, laryngeal dystonia, we have an ENT doctor who does that injections. We just help him to interpret his EMG findings. I don't touch the vocal cords. Now, in pain conditions, so this is the topic of my interest as well. We did a clinical study many years ago. This was in patients who have post-surgical scar pain where they have some mastectomy or some oropharyngeal cancer surgery, and at the scar, there's significant pain. They are taking tramadol, painkillers, which is not helping, but it's very focal pain or neuropathic pain. In these cases, local injections of botulinum toxin can be helpful. We know that botulinum toxin is not only acetylcholine, it also is the anti-CGRP effect, anti-substance P effect. That's why we are using that for migraine patients. So probably there is some nociceptive, anti-nociceptive effect that we see in these patients. And there's a good randomized control studies on neuropathic pain in trigeminal neuralgia, in post-herpetic neuralgia. And we have a nice review article published in seminars in neurology on that condition. Stiff person syndrome. Yes, it is all symptomatic control. If the patient has very prominent spasms, not improving with steroids, IVIG, plasmapheresis, you can do botulinum toxin injection. Usually very high dose is required because these are big muscles and big spasms. Hyperhidrosis, another not very obvious condition. Not many people are aware that we can use botulinum toxin. And I see they directly go for the surgery, which is quite invasive. So I feel this was something which we commonly did in US, but people are not aware about this. And I have now few patients who are getting every 4 or 5 months injection, and with a decent effect, about 70 to 80% improvement. And this is hyperhidrosis. It can be, mostly it is palm, sole, axilla, but scalp as well. And injections of botulinum toxin really helps quite a lot in these patients. And it's FDA approved, it's well proven. Drooling of saliva, another very common condition that patients suffer mostly with atypical Parkinson's or advanced Parkinson's, Wilson's disease, dystonia patients, Alzheimer's patients, anyone who is wheelchair bound, they are really having drooling of saliva. I see most common medicine is scopolamine patch and anticholinergics, which we know they can mess up with their cognition. And if the sialorrhea is bothering, I directly go with botulinum toxin injection, which is very, very safe. It is well-proven therapy, and I have many of my patients with sialorrhea who are getting every 3 months injection. And really, we don't see any complications with sialorrhea injections. It's a very simple bedside procedure. I use ultrasound to locate the parotid gland, make a marking, and do the injection. Restless leg syndrome. This is something which is also not very obvious. It is not FDA approved. It is I'll come to the evidence base. There are clinical trials, very small. The one that we did was a clinical trial in 2018, where we published this in 2018. It was a study in around 28 patients with severe restless leg syndrome, where they were on opioids. And in these patients, we had a control, and we had a placebo control, and we did injections into the tibialis anterior and the gastrocnemius muscle, and only who had severe RLS symptoms, they had significant improvement compared to the placebo group. But again, we don't have any major multi-center clinical trial for its efficacy. Someone who is really bothered by RLS symptoms, not doing well with medications, this is a good option. Now, this is the last case. I'm right on time. This is an interesting case where we published in 2014 where there's a 46-year-old lady who came who said, I cannot walk because my glute muscles are moving all the time. And this is a video. So this is the left gluteal muscle, and you can see that it is at rest, it is moving. So she has gluteal myokemia or gluteal myoclonus muscle. So patient was found to have endometriosis, and the endometriosis was sitting on the infragluteal nerve, which was stimulating the gluteus maximus muscle, and that was causing the peripheral myoclonus. And she tried all the medicines, did not help. We did botox injections exactly with the EMG guided in the gluteus maximus muscle, and she was able to walk with improvement in her muscle. So this was published, and now you can see my mentor injecting Dr. Jabari. He's now retired. I learned a lot of things from him. So the noise is not there, otherwise you could see here nice EMG recordings of the gluteus maximus muscle. Now, just last slide, I just collected this last week just to show what is my experience at Cleveland Clinic presently. We started 3 years ago, and around 300 visits of patients. So far, you can see the most common is cervical dystonia with 96 visits, and hemifacial spasm, Blepharospasm, Mead syndrome, limb dystonia, a lot of tremor conditions because I get a lot of referrals for tremor, and that is my area of interest as well. I think that's one of the highest so far in anywhere in the country, even in big institutions in US as well. So we're still learning about the tremor conditions, but that's a good number. So this is the experience been so far. Thank you.
Thank you so much, Dr. Shivam. Fantastic presentation, and we are very impressed with your Botox injections. Dr. Mehti can be here. We have just questions for 5 minutes, maybe 2 pressing questions. Yes, doctor.
Thanks, Dr. Shivam.
Yeah.
Thank you very much for this interesting presentation. Only one small question. How you get the approval from Daman or from the insurance about the main payment? Because I have a patient with capped cornea who failed even to get any approval.
Patient with what?
So, patient with sialorrhea for insurance approval.
Capped cornea.
Capped cornea. Okay.
Even we behind at the sound guided and the RR, we behind everything, but we stuck with insurance.
That is a major roadblock. For camptocornea, we don't have much evidence, so we cannot support as well. As you saw, only one clinical trial is published so far. We don't have bigger studies. So
What about others, tremors, and because it's not FDA approved, it's not in the Daman payment. Do you get approval for it?
So usually most of the population that we are seeing at Cleveland Clinic are Emirati population. I have only a handful who are Daman or so I didn't have a lot of issues with the insurance, thankfully. But few patients, it takes I need to give them some papers to Daman, and they have to fight back. I have to write a letter, and then finally it gets approved. Even if I show at least 2 studies, good evidence, they usually approve it. But it takes time. It back and forth. It takes at least few days.
I think you are Ayati, because it's not listening to us. Thank you.
Dr. Naik?
Shivam, thanks for the lovely talk. I was in fact asking yesterday. I have 2 MS patients. They have tremor, and that's not purely intentional of the cerebellar. They don't have much cerebellar systems, and they are really disabled, and I tried oral medications which are of not help. Do you think they are for your Botox, they help?
So,
or next is whether DBI helps them. Yeah.
So I would not jump to DBS because they have MS, and Dr. Fasano is here with us, so that's amazing, from Canada. And yes, MS, there is a nice clinical study published in Neurology Green Journal by Dr. Vanderbilt group, where they have patients with action and postural tremor with MS, and they did a randomized placebo-controlled study in these patients. The improvement is significant based on which muscles are involved. If it's very distal tremor, we can do better with the botulinum toxin. If it's very proximal tremor, it becomes more difficult because if they're bigger muscles and difficult to isolate. If it's mostly like the finger, index finger and the thumb, like a pill rolling tremor, or it is more like a flexion extension of the wrist or pronation supination, we can do better. But if it's more like a ballistic movements or more when they're holding the hand up, it becomes more challenging. Then we have to target more proximal muscles like the supraspinatus, deltoid. It becomes challenging. So it has to be customized based on the movement. But I usually counsel my patient that we will expect to have improvement by around 40 to 50%. If that is satisfactory to you, then we will go ahead. But otherwise, if you think it will completely go away, no, it will not completely go away.
Thank you so much. Last question. Okay. How can we differentiate between status dystonicus and status epilepticus?
Yeah. So can you hear me well?
Yes.
Yeah, I think you can. Okay. So first of all, thank you for the invitation. I'm glad to be there with you. It's an amazing program, and I see that there are thousands of people attending. So congratulations. As for the question, it's a good question. As I mentioned in my talk to many people, status dystonicus is like the status epilepticus of the basal ganglia. But there are very important features here that can help us understand the difference. First of all, EEG in status dystonicus is normal or showing slowing because of the metabolic disturbances, but certainly not epileptic activity of the brain. Second, status epilepticus, you have an evolution of problems. You may start with a clonic movement and then becomes more sustained and tonic. So you can tell it's not a classic dystonia. Third, these are people known to have epilepsy most of the time. As you know, there are conditions where the patient starts with the status epilepticus, but this is not common. And finally, the level of consciousness. In status dystonicus is not impaired at first. Dystonia starts, and maybe with the metabolic problems and extensive electrolyte disturbance, there is a problem with cognition, not with cognition, sorry, with awareness and with consciousness. In status epilepticus, the problems with consciousness is much earlier. Actually, it's even at the beginning of the manifestation. So that helps greatly.
Thank you so much. Thank you, Dr. Alfonso. I think with that, we'll wrap up the session. Thank you, Dr. Mittal. Thank you, Dr. Mehti.
Bye all.